Dear esteemed chairs, dear audience, my name is Patrik Kreuter, and I would like to introduce my PhD topic, the latest advancements in digital orthodontics. I'm a second-year PhD student at the Department of Pediatric Dentistry and Orthodontics. My supervisors are Noémi Rózsa and Dorottya Bányai. My SMS is Eszter Szalai. My mission is to help more people smile confidently, and my vision is to contribute to the development of orthodontic guidelines, providing high-quality treatments without compromise. I have two ongoing projects. Both of them are systematic reviews and meta-analysis. The first one is titled Investigating the Differences in Root Resorption between Fixed Appliances and Aligners in Permanent Dentition. Fixed orthodontic appliances often cause aesthetic and hygienic difficulties during the treatment. However, aligners are more comfortable and aesthetic, with less treatment-associated periodontal risk and improved patient satisfaction. Orthodontic treatment is one of the common causes of root resorption. This phenomenon is also known as orthodontically induced inflammatory root resorption, which can occur in almost every orthodontic treatment. Aligners previously showed lower prevalence and severity of root resorption on radiographs. However, more accurate CBCT studies have been conducted only recently. Our clinical question is, how do aligners perform in terms of orthodontically induced inflammatory root resorption compared to fixed appliances? We use the PICO framework, where the population is patients with permanent dentition, the intervention is aligners, and it's compared to fixed appliances, either conventional or self-ligating ones. Our primary outcome is root resorption measured on CBCT records, and the secondary outcome is the same measurement on radiographs. This is a linear, continuous measurement. It actually shows the linear decrease of root length. Our hypothesis is that aligner therapy causes less severe root resorption compared to fixed appliances. Here you can see the selection flow chart. After the duplicate removal and the selections, we have 6 eligible studies. 5 of them were included in the meta-analysis. The outcome measures were means with a 95% confidence interval, and the finished analysis included root resorption of upper central and upper lateral incisors. Fortunately, we were able to carry out a subgroup analysis of the fixed appliances, so we compared self-ligating fixed appliances to conventional fixed appliances as well. I would like to shortly introduce the results. The first figure is a forest plot showing the root resorption of upper central incisors, where we compared aligners versus fixed appliances. 5 retrospective cohort studies with almost 300 patients were included. And as you can see, the outcome measurement was the mean of the root length change, which is a negative value, indicating that it was a decrease in root length. The green area shows the clinically insignificant range of root resorption. There were contradictions in the literature. The most rigorous cutoff value was the 1 millimeter, thus we stick to it. As you can see, there was a high heterogeneity in the liner group, and there was moderate heterogeneity, marginally significant heterogeneity in the fixed appliance group. And none of the means of the random effects models has exceeded 1 millimeter, so none of the groups presented a clinically relevant root resorption. And based on the chi-squared test, we can see that there wasn't a significant difference between the two groups. Thus, aligners and fixed appliances cause a similar amount of root resorption when we compare them in case of upper central incisors. We were able to carry out a subgroup analysis of fixed appliances. With 4 included studies, we had the same outcome measurements, and here, as you can see, there weren't any clinically significant results either, and there wasn't a statistically significant difference between the groups. The conventional group didn't show a significant heterogeneity. The self-ligating group showed moderately significant heterogeneity. The same measurement was concluded for the upper lateral incisors on this forest plot. 4 retrospective cohort studies were included with more than 200 patients. As the measurements were the same, here we had the same conclusions. None of the groups presented clinically significant, clinically relevant root resorption, and none of the differences were statistically significant based on this chi-square test. Both groups presented a significant heterogeneity based on the I-square values. And lastly, in case of the upper lateral incisors, there wasn't a statistically significant difference between the subtypes of the fixed appliances, and none of the groups have presented clinically relevant root resorptions. What are the strengths of this study? It was the first quantitative analysis based purely on CBCT studies, and we have only included 2 arm studies. The subgroup analysis of conventional and self-ligating appliances brought some novelty as well. The limitations are that only retrospective studies were included, and there was a high heterogeneity, and most of the available studies presented at least a moderate risk of bias. Our conclusion is that aligners and fixed appliances cause similar amount of root resorption in this population, and there isn't a significant difference between conventional and self-ligating appliances. The implication for practice is that both aligners and fixed appliances can be used for patients without the known risk factors, as all of the studies follow the rigorous inclusion criteria excluding risk population. Self-ligating appliances are not superior, contrasting the advertisement of these appliances. And CBCT screenings, as we didn't find any clinically relevant root resorption, are not justified for the screening of orthodontically induced root resorption solely. For research, we need high-quality RCTs, as there wasn't any available in this topic, only with radiographs. And studies should investigate the patients with the known risk factors, as there's such a low prevalence in the known risk population that we didn't find interesting results in this field, and more standardized future studies are needed. Currently, it's under a major revision at the BMC Oral Health, and now we are addressing the questions regarding the statistics. My second project is titled Analyzing Transfer Accuracy and Debonding with 3D Printed Indirect Bonding Trays. The conventional direct bonding of fixed appliances requires high precision, as misplacement of the orthodontic brackets can cause unwanted tooth movement. Indirect bonding is more predictable and precise in bracket positioning, and also it can decrease chair time. The most novel method for indirect bonding is the use of 3D printed transfer trays. However, there's only limited evidence available supporting their clinically acceptable accuracy, and also some evidence suggests that they may be even inferior in survival compared to manual bonding. Our aim is to assess the transfer accuracy and debonding rate achieved with 3D printed transfer trays. Our clinical question is, how do 3D printed indirect bonding trays perform in terms of transfer accuracy and debonding? Here we use the PICO framework as well. The patients are, the population is orthodontic brackets, and we compare the interventions as the subgroups of 3D printed indirect trays. The primary outcome is the transfer accuracy, linear and angular measurements, and the secondary outcome is bracket debonding. Our hypothesis is that 3D printed indirect bonding trays present clinically acceptable accuracy and debonding rate. Here you can see the results of the preliminary research. We already pulled together data from the preliminary research and started working on the statistics to check feasibility. And right now we are drafting the Prospero registration. And as a summary, I have 2 ongoing meta-analyses in the topic of latest advancements in digital orthodontics. And shortly, I would like to introduce a few of my additional activities. I had the opportunity to co-author 2 Q1 publications since I started my work at the Translational Medicine Center. And also, I'm a proud supervisor of 3 TDK students who achieved great results at the National TDK Conference and the Home TDK Conference. And finally, I would like to thank you for your attention with a quote from Carl Sagan: "Somewhere something incredible is waiting to be known." Thank you for your attention.
Why did they really choose CBCT for follow-up of these orthodontic cases? Do we know anything about this?
Sure, thank you for the question. If you allow me, I would go back to the slides. So there's evidence suggesting that there are inaccuracies because of landmark identification and distortion of the radiographs. In the clinical practice, we often see that, for example, on an OPG, flared incisors or protruded incisors seem to be really short, and that's why 3D printed, 3-dimensional landmark identification may be more accurate. The most accurate way which I found was CBCTs, and there is AI-assisted segmentation of the tooth, and also measurement volumetrically. So now the most recent studies don't check the longitudinal changes, they check the volumetric changes, as in some of the cases where there's not significant decrease in length, but there is significant difference within the volume of the tooth.
Thank you. And for the radiographs, the periapical radiographs, this front area is also a very bad position, I guess, because the way you put the sensor compared to the tooth is just absolutely sometimes useless. Do you know if they used any kind of individual bite block to position this sensor holder to set the tube and the X-ray direction?
Thank you for the question. In the systematic review, I have only one RCT included, and that is on radiographs. So that's the only article that I can speak of within the study. But as far as I know, they didn't have any kind of specialization. They only used the standard frame for it. So that's why it's not that reliable.
Yeah, yes. It's not that reliable in that case.
My question is regarding your second project.
Yes.
How are the transfer accuracies measured here?
Okay, thank you for the question. So for the fabrication of 3D printed indirect bonding trays, we first need to have a digital plan of the bracket positions. So we need an intraoral scan, and then digitally we place the brackets. So this is one STL file that we can use as a pre-op documentation, and after placing the brackets, the newer scanners are able to scan the brackets themselves. Most of them have some AI assistance, so metal parts can be scanned as well. And after we superimpose the plan and then the scan with the bonded brackets, we can check the differences in several directions. So linear measurements can be carried out in 3 directions: the vestibulo-oral, the occlusogingival, and mesiodistal displacement of the brackets. And also the angular changes can be based on the angulation, the torque, and the rotation of the brackets. And for these, I have some standard values here. The American Board of Orthodontics has a scoring system in which they say that linear changes in bracket positioning below 0.5 millimeter and angular changes below 2 degrees are clinically acceptable. And most of the studies that I found use this as a gold standard to compare accuracy.
Root resorption happens all the time with orthodontic treatment. Yes? Yeah, okay.
Almost, yes.
And almost, yeah. I would imagine it happens all the time, and it's just, is it detectable or not? So how do we define if it's clinically relevant? Because I mean, you know, some of the pictures you show, that must be clinically relevant when you've lost. I know it's more than 1 millimetre, but you know, I mean, there must be something where we get very worried. I'd be interested in that. And then when does it occur? So my limited knowledge is that it occurs during the orthodontic treatment, but can it occur afterwards and continue to occur? And I always thought it was related to the amount of force. But at least from your review, that's, well, maybe retainers are providing just as much force as the fixed orthodontics. I don't know. There's lots of questions from your results that are whizzing through my little brain.
Thank you for the questions. These are really interesting questions. The first is, how do we decide if it's clinically relevant? During my whole year in this project, I couldn't find an exact answer. Sharpe classification is one of the most known classifications for root resorption. And for example, there they discuss the 3rd grade root resorption, which means that more than 1/4 of the root is resorbed. That is a severe one. But even patients with losing half of their root can have stable teeth. So it really depends on the patient. And unfortunately, there isn't a strict guideline stating that which should be mentioned as clinically relevant. I think the most relevancy of root resorption can be investigated when we talk about the retreatment of patients. some patients visit our clinic who needs to be retreated, but due to previous treatment, there was such root resorption that we cannot really warranty that that it's not going to get worse during the treatment. And yes, one of the main questions is biomechanics. Why does it occur, and to how much extent does it occur? The interesting thing is that some of the included studies, individually, they all stated that aligners are significantly better than fixed appliances. And if I dug deeper, I found out that some of them are sponsored by aligner companies. We also found one that was copying results from another paper, so that had to be excluded. Aligners are known to be easier to work with, and they have their benefits, but the predictability of the tooth movements and the root movements can't be compared with the fixed appliances. So, for example, some studies say that extrusion movements have like a 30% predictability, and overall the movements have like a 50% predictability compared to the digital plan that we receive from the company. So the question arises that how can they cause such severe root resorption even though they don't even move roots that much? And the answer may be that the study design of the included studies is not that good, because we wouldn't be that interested in the means, but we would be interested rather in odds ratios, risk ratios based on the, for example, Sharpe classification. So out of the 1 to 5% of severe cases, we should only report the severe cases and not have continuous values, but rather dichotomous values.
I heard again that it's almost 100% is the root resorption, but on your slide you had a ratio from 20 to 100%.
Yes.
So, so that doesn't mean it's 100. It's,
yes.
There are quite a few which has no root resorption if we are taking the 20% value.
Yes.
So what is the truth now?
Yes, that's why I've added almost when the question arises.
20% is not almost.
Yes.
So 20% is.
Yes, in another article that I cited in the paper, it said that in the population they've investigated it was 90%, and that was a more reliable study than the one here. And also the question arises that was it sufficiently investigated if it has occurred? Because the CBCT studies showed that almost every patient had root resorption, if not all of them. And the radiographic studies that have these prevalence data, they might underestimate the number of patients who have root resorption. So I think that's where the difference comes from.
Regarding a second project,
yes.
I'm just curious about the practice nowadays. Is this method used in everyday practice or not yet?
Thank you for the question. Depends on the clinic and the country. There's a trend that from orthodontics, most of the tasks try to be delegated. So, for example, if we let the CAD/CAM specialist place the brackets digitally, the chair time decreases as we can bond the whole arch or one quadrant at the same time. But also it has much higher expenses than the orthodontist placing the brackets themselves. So in Hungary, it's not that common to have indirect bonding, even though it does have its benefits. But most of the clinicians prefer placing by hand because it makes a bigger margin for them.
Okay. And the other thing that, what do you think, those doctors have enough courage to use this technique without a cast, or they also print the cast on, they are able to evaluate the placement before they do the actual placement of these brackets?
Yes, it's a good question. So directly 3D printed indirect bonding trays, I know that it contradicts somewhat, are the newest methods. And basically most people who use indirect bonding, they either have a technician that has a physical cast or 3D printed cast where they bond the brackets after isolation. Then they do either a vacuum formed hard one or one with the silicone, and then they remove it with the brackets and transfer it. So the absolutely digital way is a new one, and it's not really in practice here in Hungary yet. With
this transfer tray, do you think that the bonding technique is going to have an effect, because if I place these brackets one by one, I think adhesive technique, being very sensitive, is going to be much more sure, right? But if I do this all at once, I think it has more questionable points.
Yes, thank you for the question. Evidence shows that there are trending inaccuracies. So usually when we put on the indirect bonding tray, we either not put it gingivally enough. So usually there's an occlusogingival transfer inaccuracy. And also, as we don't press it on the tooth, there's an orovestibular discrepancy as well. So we aren't that sure that we can remove all the excess bonding material. We need different bonding material because the excess then, after it's light cured, is harder to remove. And yes, also because of the transfer tray itself, it does show some inaccuracies. So I think for a while, orthodontists will still have the opportunity to work with direct bonding. It's not going to take over. But for those practices that want to maximize their chair time, it may be a good opportunity to use this.
I'm just wondering the differences between a surgical guide and this guide. So when we use a surgical guide, there are so-called windows on it, through which we are able to evaluate the placement of the guide. Is this any possibility at this case also, or it's not in the literature yet?
Thank you for the question. It's one of the biggest challenges right now to sort the articles based on the different tray designs. So first of all, we can have hard trays and soft trays. Usually the 3D printed ones are somewhat soft, and also the design of the trays, they can either cover the bracket fully, they can cover it half, or there's a study from 2024 in which they have tested a new type of bonding tray which actually did not support the brackets, so it was still placed hand by hand, but in an L shape or the reducted way only by one platform. It guided the positioning of it, and that way it was easier to remove the excess, and we could control the force that it's pushed with.
On your pictures we see nicely aligned teeth regarding your second project. Well, what if I have misplaced teeth? Could it be a limitation for usage of the trays?
Thank you for the question. Absolutely. Most of the studies that I came across had the inclusion criteria of maximum or moderate crowding, for example. So yes, if there's a big rotation or if there's big crowding, they cannot be used. In that cases, maybe segmenting the tray can be beneficial, but I think those are the cases where it's never going to be enough to be changed.